Hello, good afternoon, and many thanks to MBRRACE for asking me to speak today. My name is Sarah Hillman. I'm a GP and I'm also an academic clinical lecturer at the University of Warwick in primary care. And I'm going to be talking today about bridging the gaps before and after pregnancy. So in this presentation, I'm going to tell you a little bit about what comes before and after and why that matters, and how pregnancy also fits within the sort of helicopter view that we have of GPs of women's healthcare. I want to talk about MBRRACE and how it's actually the tip of an iceberg in terms of women's health, the problem of existing health conditions, the contraception and preconception period and postpartum periods, which periods that GPs are involved in, and also longer term health for women. And I'm going to talk about the perspective of the GP. So I think all too often we think about pregnancy as a distinct life event that happens, but actually it is so much more than that. GPs are probably least involved in routine care during pregnancy, but are very much involved in optimising existing health. So that might be optimising the control of an existing disease such as diabetes, often very much involved in the preconception period, and that might mean helping somebody who's overweight to lose weight before pregnancy, or thinking about the medications they're on and if they're the right ones in pregnancy and whether they should change or continue or stop. And we're also very much involved in the postpartum period. And what's particularly important is to recognise that actually the conditions that might be pre-existing or developed during pregnancy and the postpartum period have an impact on long-term health. And of course, as GPs, that's where we sit as well. So what do I mean about MBRRACE being the very tip of an iceberg? Well, of course, what we're trying to do with MBRRACE is review the cases of women that have died during the designated period, and then try and look at the lessons that we can learn and reduce the mortality. But of course, beneath those figures of women that have died, we also have women with poorer health. And what we need to consider with MBRRACE as well is not just reducing the numbers of women that die, but also making sure that we can reduce the number of women with poorer health and expand the number of women that live in good health, that have good health between their pregnancies, and have good health in the long term as well. So of the women that died between 2018 and 2020, 60% had pre-existing medical conditions, 37% had pre-existing mental health problems, and over 50% were overweight or obese. There are, as we know and have known from previous MBRRACE inquiries, the fact that actually there are particular demographics of women that are at increased risk of dying in pregnancy or postpartum. So they are often older women, those from geographically deprived areas in the UK, and a woman's country of birth matters as well. So a woman that's born in Bangladesh or Ghana might have 3 times an increased risk of dying compared with a woman that was born in the UK. We've mentioned multi-morbidity, but it's also worth considering this concept of severe and multiple disadvantage. Severe and multiple disadvantage is the co-occurrence of serious social problems such as mental health problems, substance abuse, domestic abuse, and 11% of women that died between 2018 and 20 would have fitted into this category. So I want to think for a moment about the fact that actually the conditions that happen in pregnancy can be part of what we call a syndemic situation. So that's when 2 or more interrelated biological factors work together to make a disease or health crisis worse. So if we think about 2 conditions that we as GPs see a lot of, diabetes and depression, the fact that these 2 conditions, if also subjected to adverse interactions, be those biological, psychological or social, substance abuse or poor housing have a much greater risk of having a negative health outcome. So that might be a woman going into DKA and then subsequently having a stillbirth. And severe and multiple disadvantage that I spoke about before promotes disease clustering. So the fact that these conditions occur together. What I'm going to do next is talk through, I'm going to talk through a few cases. I'm going to talk through, the first is a woman in the preconception period, and then two in the postpartum period. So the first is a multiparous ethnic minority woman with poorly controlled type 1 diabetes who had known peripheral neuropathy, chronic pain and hypertension. And she was admitted with abdominal pain and vomiting and found to be 12 weeks pregnant. Her HbA1c was 92, so she's poorly controlled. And her medications at that point were an ACE inhibitor, a statin and pregabalin. And they were stopped and she was started on methyl-dopa. She subsequently had multiple readmissions with poorly controlled hypertension and DKA, and on one occasion she tested positive for cocaine. She had a caesarean section at 30 weeks and was readmitted 2 days after discharge with poorly controlled hypertension. 2 months postpartum, she was admitted again with DKA, and at this point her children were taken into care because of her poor self-management of diabetes and the continued use of crack cocaine. She had a termination of pregnancy just 8 months later because of a progressive complication of her diabetes. So here we see a case that really emphasises those ideas of complex existing comorbidities, and also this woman would have fitted into the multiple and severe disadvantage category that I was talking about. We really need to consider in these sorts of cases contraception and how we can also make existing health conditions more stable in the preconception period. For instance, in this woman's case, her diabetes, and addressing those substance abuse and social issues really were key here to a better outcome. An MDT approach really would be key here. And obviously the maternal medicine networks that are being set up would really be particularly helpful in making sure that we respond to changes through pregnancy, birth, postpartum, and plan for the next pregnancy. Now, guidelines do exist to optimise care of adults with multimorbidity, but it isn't clear how they're considered in the context of pregnancy. So the next two cases are those that happen in the postpartum period, and GPs might come into contact with. The first is a mental health case. It's of a non-English speaking woman who contacted a health visitor at 3 months postpartum concerned about her baby, and she herself had not slept for over a week. She was directed to the emergency department, where the psychiatric liaison team did not identify any low mood using a telephone interpreter. She was not referred to a specialist perinatal mental health team. She was commenced on an antidepressant, but did not continue as she was breastfeeding. And a week later, her health visitor referred her to the perinatal mental health team. She was called by a member of the specialist team within the week after referral, who offered talking therapy, but she declined. She was also referred again to the specialist team, who suggested that she should be advised to attend the emergency department, but did not attempt to coordinate an urgent assessment, and she died by jumping from a height 3 days later. So some of the key messages to come out of this, but particularly poignant for those working in acute and general practice, are that if a woman has severe sleep disturbance, we really should be considering underlying mental illness. Obviously being aware that there is stigma around mental health, but that stigma may be more prevalent in some cultures where more than others, and might influence a woman's willingness to disclose, combined in this case with the fact that she wasn't an English speaker. Many people were involved in this case, but there was a lack of ensuring coordination of referrals and therefore ongoing care. And for women that do present with pre-existing mental health that worsens in pregnancy or postpartum, or a new mental health diagnosis in pregnancy or postpartum, is an awareness that this might actually be a window into longer term mental health problems for that woman. Finally, I just want to take you through a cardiac case, and this is of a young, obese, white British woman with a history of antiphospholipid syndrome and previous thrombosis, who was commenced on dalteparin and aspirin in pregnancy. She developed early onset preeclampsia and had a caesarean birth in the early third trimester. She declined to recommence warfarin while breastfeeding and remained on dalteparin for several months. On various occasions, postnatally, both in outpatients and GP appointments, the woman's blood pressure was documented to be high, but it was not treated. She developed chest pain and was reviewed by the GP, and she was reassured that the pain was likely musculoskeletal after a normal ECG. A few months later, this lady collapsed in the street from a cardiac arrest, and cardiac catheterization identified an occluded coronary artery. Life support was withdrawn and she died from a hypoxic brain injury. Here we see also emphasised the fact that pre-existing health conditions such as obesity have a major impact, and that conditions that happen for the first time in pregnancy, for this case preeclampsia, raise this woman's chance of having cardiovascular disease. Postpartum blood pressure control is paramount for both the short and long-term health. And women who have preeclampsia should be given a clear care plan on discharge. It's likely in this case that acute coronary syndrome wasn't diagnosed due to confirmation bias and the idea that the GP thought that it wouldn't have occurred because of her age. So pregnancy is an opportunity to address pre-existing conditions, both mental and physical health, and improve long-term health. It's also an opportunity to look at the impact of new conditions found in pregnancy for the first time, preeclampsia, diabetes, an injury to the pelvic floor, or new mental health diagnosis. And they really can provide a window into longer-term health. Pregnancy is a time when women may be keen to engage with lifestyle change and an opportunity to improve the health of the whole family. From the GP perspective, we're often the main point of care before and after pregnancy, in addition to health visitors, and the main point of care for existing health conditions and then longer term health. Now, I'm part of GPCPC, which is GPs Championing Perinatal Care. I'm a member. The chair is Judy Shakespeare, who will be answering questions today. We're really keen to get as many messages out to primary care as possible. And if you have ideas about how we can do this, we would really welcome them. Thank you once again for your time and for listening today.